Hello, everybody here. It's so good to see you all. And hello to everybody online. We're so excited you're here. And this is really for you, our wonderful international CF community. I have funding disclosures. I have grants for my research from the NIH, CF Foundation, Rosenau Foundation, and Center for Disease Control. And then today we're going to talk about the diversity of our CF population, the challenges of equity in newborn screening. We're going to describe disparities in disease severity, the lack of diversity in CF research, and international disparities. So much better. So I wanted to introduce myself because many of you only know a portion of who I am. So I am a pediatric pulmonologist. I am a CF researcher. But first of all, I was a member of the chronic disease community. So this is me at 3 years old with my older brother who has Down syndrome. And so I wanted to be a doctor from the very beginning. And part of why I wanted to be a doctor is to really advocate because our family had doctors that were not optimal. And so I wanted to be the doctor that our family didn't have. And so this has always been my first identity is really advocates. So I became a pediatric pulmonologist. And during my first weeks of fellowship with Dr. Dennis Nielsen, who many of you know and love, we met this wonderful patient, and she was 12. She is Latina, and she had very severe lung disease. She did not qualify for a lung transplant. And she would speak of her dreams of going to France and her dreams of growing old. And we were in a panic because she was dying. And we were very lucky that ivacaftor came out at that time. So ivacaftor, many years ago, was only approved for one mutation. And she had a different mutation that was similar, a gating mutation. And so with Dr. Dennis Nielsen, we were the first group to use a modulator off-label, and she dramatically responded. She had never slept through the night because of her coughing. Her sweat test went from 93 down to, I believe, 10. She was able to take a dance class like within days, just miraculous. And this was so powerful to me. This is her a few years ago, college graduate. When we told her mom what we were doing, her mom cried and said that she, in a panic, I didn't think I would ever have to save for college. So I think there was this so powerful in being able to create dreams. And very quickly after, we wrote the report. And when I was at NACFC the next year, I got to meet this lovely family whose daughter had the exact same mutations. And from our case report, also got ivacaftor and also had dramatic response. So in these moments, I had patients who were similar, who were not able to live their childhood because they were living in the hospital all the time. Or I had this patient who's one of my very favorites who died before she was able to live out her dreams. And so it was in this, we went to the literature and there was just no research in this community. And so we decided to start doing work in here to figure out why did some patients have more severe disease than others? So I'll start by saying cystic fibrosis occurs in people of all races, all ethnicities, all ancestries, all backgrounds, all sexual orientations, gender identities, with those who are rich, those who are poor, those from all different countries. And we really need to celebrate that diversity of our CF community. We need to have them included in all aspects of treatment and of care and research and at these conferences. And we need equality in that. We need that everybody in the CF community to have great outcomes. And part is this, that the CF population is becoming more diverse. So this is not a white person disease. It's just that we ignored the rest of the community. And so you can see that there's lots of many races and ethnicities in the patient registry that are represented. But even more important, in 2024, a quarter of new CF diagnoses identified as either Asian, Black, Hispanic, or multiracial. And so we know that our community is very rich, and we need to really celebrate that and figure out how to make treatments and everything work for our entire community, not just for some. So one of the big areas that I work in is newborn screening and CFTR variant panels. So when newborn screening was started, it was thought that it was going to be really equitable. It was going to benefit everybody. And they specifically chose these 3 babies, a baby who was Black, a baby who was Hispanic, and a baby who was white for the cover because they thought it was going to benefit everybody. And boy, were we wrong. So this is work that we did with the Rosenau Family Foundation and the Center for Disease Control through interviews with families trying to understand about their experiences with being diagnosed newborn screening. So over 40% said that they were told that their race and ethnicity affected the likelihood of their baby having CF in those initial discussions. 20% said that their baby was treated differently because of their race and ethnicity, and a quarter said their diagnosis was delayed due to the race and ethnicity. This is just so wrong. And we see this also when we look at the raw data as well. So infants who were Asian, Black, Hispanic, or mixed race were seen at an older age compared to those with non-Hispanic white infants. And this was we looked at what was the first encounter with a CF center, whether it was a visit, a sweat test, and they were taking a longer time for diagnosis. And we know that those first couple of weeks, it's so important to get started on treatment right away. And we know this when we look across the entire registry data as well. So what you see here in yellow is the CF population born 2007 to 2020. So this is when newborn screening started, by race and ethnicity along the left side. And when you compare, the pink is the false negative percentage, and the blue are those who got diagnosed over 180 days old. So very delayed diagnosis. So if you look at the Black population, you can see that they're twice higher proportionate for false negative and late diagnosis. Hispanic population, you can see that even though they only made up 9% of the CF population in that time, they were over 15% false negative, and almost a quarter of those very late diagnoses. The same thing for mixed race. What we see is the opposite for those non-Hispanic white population. They made up about 85% of the population, but you can see they were only 70% and 62% of false negative and late diagnosis. So you can see we have a lot of work to be done. Part of this is that CFTR variants are based on the frequency of what variants you may have is based on your ancestry. So where your family is from, where those mutations originated from, and they vary. So class 1 to 3 mutations, the dark blue. So you can see very different distributions. Class 4 to 5 is orange. Unclassified, which means that your variant was known, but we can't tell you anything about it. You can see it was like a quarter for Black or Hispanic people with CF. This is improved. This is from 2020. And then not fully genotyped. So there are still people who don't know all their variants. And this is showing, this is a little bit difficult to think about, but this is the most frequent CFTR variants by race. And they looked at the top 50. And so they just said, like, what's the most common variant? And they ranked them all. And then they compared about, well, what variant only showed up in that one race? And so 4 of the top 50 in people who were white were only in people who were white. 20 out of 50 in those who were Hispanic were only in those who were Hispanic. 14 out of 50 were in those who are only in Black, and you can see 18 out of 50 are only in Asians. So that variants that may be rare overall are not rare for that specific group. And so, but we can't really lump people together. So the Latino CF population is not one group. They are very diverse, coming from all over the world. And what we know is that their variants reflect that. And so this is the variants that are greater than 2% frequency in these studies. So there's multiple studies I put together. So you can see Delta 508 is still the most common. But you can see, look at, it goes across Spain, United States, Southwestern US, and then Southern California. You can see their variant frequency is very different, that there's variants that are common in one group that aren't even in other ones. We did a really interesting study almost a decade ago now, where we went into Puerto Rico and Dominican Republic, and we sequenced people with CF and their gene variants. So those two islands, we should have put a picture up, are very close together. Their gene frequencies completely different from each other because who moved to those islands was very different. So I think it's really important to reflect that. Not only that, but we know that our Asian CF populations are also equally diverse and come from all over the world. So this is a beautiful study that compared United Kingdom and Canada, and they broke it down by South Asian versus other Asian, which is once again a really big category. And you can see the CFTR variants are not at all similar. So once again, this is above the 2% allele frequency. You can see very different allele frequencies. And this has a lot of problems for when you think about you're using a CFTR variant panel, like what's going to work for prenatal screening, newborn screening, detection, and then also for CFTR modulators, right? So if some of these quote unquote rare variants that are common one don't have a modulator that's approved for them, then you're going to have a huge proportion of that group that's not going to have access. And so one of the things when my research is always trying to figure out, well, what do I need to do to advocate for real change for people? And so we focus on newborn screening. So first, newborn screening will go into a lot of detail, but it starts with immunoreactive trypsinogen level, IRT. All states do some form of a variant panel, and then some states do sequencing. This is now 2 years old, so it's changed, but you can see that the number of CFTR variants that are detected or screened for in states widely varies. So very, very different. And so what we did is we looked at the most common CFTR variant panels, and we looked by race and ethnicity to see how they would work. So this is a really common panel. It's a 23 variants. And you can see overall, it would detect one variant in 93% of the population. So a lot of states use this, and they said, this is great, pat themselves on the back. I love this. And then we said, when you break it down by race and ethnicity, it would only detect one variant in a little bit over half of people who are Asian with CF. And you can see only 3/4 of people who are Black, and then it goes up from there. So really poorly performs in certain groups. Now, some states were doing a 139 variant panel, which sounds like so much better, and they thought that they were doing so well. And you can see it still performs really poorly in people who are Asian. It only detects less than 3/4. And this is only detecting one variant and still misses about 20% of people who are Black. So then we looked at the, not the most recent CFTR2 panel, but the 2021. And although it went up to 95% overall, it still only detected 77% of people who are Asian. Much better for other groups, but still a huge gap when we're thinking about that. And so what we really need to understand is that where a child is born in the United States really determines the likelihood that they're going to be diagnosed early by newborn screening and have the best outcomes. And this just seemed really unfair. And when we were talking to newborn screen programs, they said, well, we can't make a change because, it involves the government, it involves money. And, unless we have a policy or a guideline on it, we can't advocate for change. And so we said, great, we were going to write you a guideline so that way you can advocate for change. And so we did that. So this is the first ever cystic fibrosis newborn screening guideline. And if you want it, it's available now. It has been for the last couple months. There's a QR code up here. And this is part of our team. And this is, we addressed all aspects of newborn screening as part of the guideline. So I'm going to walk you through this. So all newborn screening starts with IRT. And so we made 2 guidelines addressing the immunoreactive trypsinogen level. And then we did 3 guidelines looking at the variant testing, 1 guideline on sequencing, and then 1 guideline on communication of the results. And one of the main things that we did that really inspired a lot of change is that we also recommended that all newborn screening programs should aim to reach 95% of true positive detection rate of infants with CF across all ancestral groups. And this is a huge change because this is what the newborn screening programs really needed to improve their algorithm. So I'll walk you through. So for that first test, you have to pass the first test to even get to genetic testing. For immunoreactive trypsinogens, we recommended that they do a floating IRT cutoff. So where it says like, oh, the top 5%, because IRT levels change with the weather, with temperature, with even the batches that they use to make sure that there wasn't babies who were just getting missed completely. We also recommended, let's see on here, that oh, it's missing one of them, that they also have a very high IRT cutoff. So those that have maybe not like a level of like 300, very, very high, that no matter what, that would be a positive newborn screen. We recommended that they would do testing of the variant panel at least twice a week because some states were only doing it once a week and it was causing delays depending on what day of the week you were born. and that they include all known CF disease causing variants. So if you don't know, there's about over 1,100 definitely CF causing gene variants right now. And yet most states were only testing for like 20 to 40. And it seems very unfair that since we know those gene variants would definitely cause CF, that we wouldn't do it as part of our screening. So we recommended all for CFTR2. And that if they didn't do CFTR2, because we know a lot of states can't change right away, that they implement screening and then sequencing. So sequencing is not just where you do a panel, we look for specific ones, but we actually look at the entire gene. And then we talked about how to avoid increased carrier detection, CRMS, and some of those other aspects that cause a lot of families, a lot of distress and stress. And then here's the very high RT cutoff. So we really thought about a lot of aspects. And then we've done a lot of work on trying to think about making sure that both the CF Center and the primary care doctors are notified at the same time. So that way the families can get accurate information right away and people aren't falling through the cracks. So it wasn't just enough to make guidelines, right? You have to help states. And so what we've been doing is CF newborn screening collaborative groups that started in 2022, where we partner with state CF teams, state newborn screening teams. They go attend these together, and then they attend it with other states. And we first started with just 2 topics, algorithm changes or communication issues. And what we did is monthly calls where we actually help them all make changes and work through issues together. So, community is better, learning from each other is better. So we just started our next set. And so now the majority of states are actually participating in this. And we're working on 4 different topics: RT cutoffs, education about CF and the results, sequencing, and then communicating the results. And on top of that, we're doing about monthly expert webinars where we are talking about different deep dive into these discussions, including we recently just had one about the family impact of CF newborn screening. So this QR code will bring you to all the previous talks as well if you want to listen to them, but we've just had some amazing results. So almost every state right now is working on either implementing change or figuring out how to make change to improve the detection for all people with CF. With the Center for Disease Control, we also made new information sheets about cystic fibrosis. Yes. IRT. Yeah, so IRT is immunoreactive trypsinogen. So when babies are born, they all get a heel stick for a blood test. So that's the initial test. It comes from the pancreas. So it's elevated or high in babies with cystic fibrosis. It can also be high if the baby underwent a lot of stress. So that's why it's not our only test for CF. And so that's the first screening test for cystic fibrosis. Yeah, that's a great question. So we have lots of different infographics and handouts and information that are created for pediatrician offices, newborn screening, or newborn nurseries, because there was no information sheets that actually reflected that, the diversity of CF. So, and then why does detection by newborn screening matter? Once again, this is really because so many families that are not white face so much discrimination in trying to get diagnosed after their newborn screen is negative. And so here are some quotes, and we could do a whole talk just on quotes from here. So this is a family where their older child already had CF, and they had another baby. The baby passed the newborn screening, and they were told, we should be really happy. Your mom was crying because the symptoms were exactly the same as the brothers. He was salty, she would lick him, and they said, you are being paranoid. So then they went to the OB/GYN, and she too stated the results are accurate and to believe what we were told. She thought it was so funny the mom was licking the baby, she fell off her chair. So finally they convinced the pediatrician to send an order for a sweat test to calm mom down, and of course, it was positive. Took 4 months to be diagnosed. There's another quote, we have to be at the brink of death before being diagnosed because of the persistent stereotype of being a Caucasian disease. And then one last quote is, my baby and family suffered tremendously during those 4 months. And so we know that in ideal world, doctors would recognize that CF occurs in everybody, would recognize these very classic symptoms in order to test, but that's just not the case, as we really need to work on newborn screening to avoid all these biases and discrimination. So we're going to switch topics a little bit to talk about some of my original work about disparities in disease severity. So after encountering those patients in fellowship, we did a lot of work with the CF patient registry, and we showed that people who are Hispanic had a 5.7 percentage points lower FEV1. It started at 5 to 6 years old. So right away, there was a persistent lower lung function that even with the people with the same genetics, Pseudomonas, MRSA, everything, it was much lower lung function. Another group has shown that people who are Black with CF had a lower lung function. So we then did some work to look at variation across the country. We found that here on the West Coast, the disparity is twice as wide as any place else. So here it's 9 percentage points, and we don't know why. So we've now done some work in infections. So we found that Hispanic children with CF are increased risk of having Pseudomonas, of converting to more severe forms, multi-drug resistant mucoid. Not only are they at increased risk, but they also acquire at an earlier age. We found the same thing for staph and MRSA as well. So increased risk, younger age of acquisition. And then a lot of people tended to say, well, is this just from their socioeconomic status? Is it just because they're poor? And so we said, well, we'll show you. And what we did is we broke it down by multiple measures of socioeconomic status, and it didn't change the risk at all. So the risk differences were persisted across those when looking at different forms of wealth and not. There's a new paper recently out looking at risk of cystic fibrosis related diabetes. So they found that the non-Hispanic Black CF population had a higher odds of CFRD, so cystic fibrosis related diabetes, at baseline than the non-Hispanic white CF population. And then they took those people and they followed them over time, and they continued on their studies. So they found that that risk was not the same by how old the patients were. So it was, if you broke it down by their age groups, you can see that those who were younger, there was a much bigger difference in the risk than those who were older. And then when they followed them over time to see who was at risk of developing CFRD over that time period, they found that the non-Hispanic Black CF community had a 40% increased risk of developing CFRD, and the Hispanic CF community had a 19% increased risk of new CFRD compared to our non-Hispanic white CF community. And then this is older data, but it still holds true, is that Hispanic CF community has an 85% increased risk of death. The Black CF community has a 48% increased risk of death, and that they die at a younger age. And because of issues where these communities don't have equal access to modulators, we have found there's a new study showing that, that the disparity has widened, so that there's worse gaps now because of modulators. And so one of the areas that we wanted to look at is diversity in clinical trials. So these groups have much more severe disease. Hopefully they were being studied. And of course, they were not being studied either. So what we did is we looked at, for every single clinical trial that was published in a year, what percentage were by race and ethnicity, and then looked at the CF population at that time. Now, mind you, the majority of studies did not even report race and ethnicity in their studies. So if you look at how when they're describing people, didn't even bother to mention race or ethnicity. So, and you can see this is Hispanic CF population that many years there was 0 studies who reported including someone who was Hispanic. And you can see never did ever approach even like the representation of the community. This also held true for people who were Black. And then very sadly, this is our Asian CF population. So there's only 2 studies who even reported anybody who was Asian. And of course, never even close. And I would like to tell you that advocacy has really helped this. I didn't include it in this because I don't we have a lot to cover, but we have not made progress in this when we've done updated results, including many of the modulator studies has very low rates of race and ethnicity. And at one point, when the modulators in one of the largest journals did not report race and ethnicity, and I was told that there was no space in the paper. So I think we need to start prioritizing this, because if we have our sickest patients who aren't included in studies, we're not doing good research. So, and it's not just by race and ethnicity. So like I said, our population is really rich and diverse, and LGBTQ people with CF really face a lot of health inequities, outside of CF. And there was never really any studies within CF. And if you look at other research papers, very low rates of actually discussing this at all. And so Pride CF is one of our first big studies that really tries to understand, how does this, all these experiences affect being with CF? And they're doing it in 4 different ways. Raksha is leading one of these studies, which is wonderful. And what we'd like to do, we really want to represent this entire community, and they are recruiting right now. So if you know someone or if you take care of people, we ask that you ask them to be involved. And right now they're doing a lot of interviews with people as well as collecting data. So I think that when we think about, well, what are we researching, what are we studying? If we're only ever looking at a small proportion or a small segment of our CF community, we're just going to be missing a lot. And speaking of our entire CF community, so our international CF community is so important, and that we know that CFTR modulators came out, they have not been accessible for many reasons to people across the world, even though they are, wonderful disease transforming drugs. And a big part of this is the pricing for these drugs. We're record-breaking, headline making, and has been a real barrier. And we know that this doesn't have to be the case. We've seen this with HIV drugs that have been made accessible to people across the world, countries across the world. And so, and this is even in high-income countries. This is in Ireland, that there is, for years, children with mutations that were approved that were not able to get drug. So I've been speaking about this, and we continue to ask that all people with CF be able to get these drugs, to be able to live and dream because of these drugs. And this is a news article that I'll just read a quote. Put simply, the company is not only refusing to bring a life raft to people drowning with CF in poor countries, it's also blocking others from deploying their own life rafts to help people who need them to stay alive. And so, we always want to speak out that, really all people with CF deserve affordable access to life-saving medications, including CFTR modulators, and that access to modulators is going to become an issue even more in our own country. We, with the CF Foundation, have done work about the cost of care to people, and it's called the Cost CF study, if any of you guys participated. And even people in the United States with high income face significant burden for all the expenses that it takes to take care of yourself and to afford all these drugs. And it's only going to get worse. So with Medicaid cuts coming up, it's going to affect a lot of people with CF. A lot of the affordable care access, the funding is being cut for that. So plans are going to go up. And so this is going to be a huge problem. And we really need to figure out a way, especially with gene therapy, hopefully looming on the border, is how can we have our CF community be healthy and be able to dream without going into incredible financial debt. So we need a lot of work and advocacy in this area. So when we think about what causes health disparities, so you take a bigger picture and say, well, why is this going on? There are so many different things that affect CF, from at the top or like community level, things that you may be affecting it to your own individual level. And so one of the things that we are going to be moving into studying, hopefully this next year, are environmental exposures. So, your lungs are a filter to the world around you. We heard some microbiome discussions yesterday as well, but it really just filters in. And so perhaps it really matters to your CF whether you grow up close to cars and streets, or are you growing up on the beach exposed to nature? Are you growing up close to pesticides and exposed to other chemicals? Do you live in California with the wildfires? So this has not really been studied in CF overall, but definitely not looking at why some people have more severe disease than others. We have a pilot cohort here from California from my time in San Francisco that we found that Latino children and non-Latino white children had very different environmental exposures from indoor pets to outdoor pets. But really in particular, if you look at the high rate of mold exposure and pesticide exposure in the Latino population is really concerning. But it's really interesting, look at the non-Latino white population has very high rate of smoke exposure. So this is tobacco, marijuana, vaping exposure. This is all self-reported by the parents. So starting this next year, we're going to be doing a home air pollution in children with CF study called Heroic CF study, where we're going to be measuring air pollution inside and outside of their homes for a whole year and really understanding like what behaviors are associated with increased air pollution or not. We're going to be correlating it with health outcomes over the year. We're also going to be doing retrospective looking at air pollution during the pregnancy, childhood, and looking and seeing at how chronic air pollution exposure goes in. And we're going to be doing microbiome and inflammatory transcriptome data research as well with the air pollution exposure. So we're very excited about this because we feel like this could be something that could really be something we can improve on. The other exciting we're doing is we did a whole cohort of children where we followed their microbiome and transcriptome. So transcriptome is like your gene expression. So what is actively going on? And we looked at healthy children, children with CRMS. So those are kids who have positive newborn screens but don't have CF. People with CF when they were well and people with CF when they're sick. And we found big differences in the Latinx versus non-Latinx population. So the blue means that these are all good bacteria or microbiome. The blue means that it's more depleted. So you have less of the good bacteria. And you can see this is between the circle is the bigger difference between Latinx and non-Latinx groups. So you can see the Latinx group is overall very depleted microbiome. And then when we broke it down by healthy and CRMS, you can see that those two columns on the left, no difference between Latinx and non-Latinx. But when you look at CF well, you can see that it's more depleted in Latinx, non-Latinx, and then also in CF sick. So the lower it is, the more depleted of the good bacteria. And what's most worrisome to us is this. If you look at between the Latinx CF well group, they look the same as the non-Latinx CF sick group. So those kids that were Latinx that were saying that we're well, we don't have increased respiratory symptoms right now, they look exactly the same as the CF sick group. And we did a lot of work on inflammatory transcriptome, so inflammation, and it looks the same, where that there's a big difference. So we're working on getting this published, but really interesting results that when you think about health equity and health disparities, that there's real differences going on in the lungs. And so I just wanted to end you with this. So all people with CF deserve to dream, and they deserve to live to see those dreams fulfilled. And so all of us as a group, and whatever part you may play, need to advocate for that, because all this research and numbers are all individuals' lives. So I thank you for being here and welcome any questions. So.